This lecture will go over disease-modifying antirheumatic drugs. The types of drugs that we're going to talk about in this lecture are drugs that will be used to treat disorders that are immune-related, ones that regular NSAIDs just aren't quite strong enough to treat the symptoms of. So when we see these disease-modifying antirheumatic drugs, there's a couple things to think about. These different types, so immunosuppressant and immunomodulators. These are medications that are changing the patient's immune system, right? So it's turning the patient's own immune system down a little bit, because these types of conditions that we're talking about, whether it's rheumatoid arthritis, psoriasis, psoriatic arthritis, Crohn's disease, these are autoimmune disorders. So it's the patient's own immune system causing damage within their body. So if the physician isn't having much luck with the medications they're trying, they might use these stronger medications, immunosuppressive and immunomodulators, that will turn down the patient's own immune system, because it's actually the patient's own immune system that's causing the problem in their bodies. So side effects from these disease-modifying antirheumatic drugs. Infection obviously would be a big one. If we're turning down a patient's immune system, that places them at increased risk for infection. Some of these medications can be pretty strong and kind of harsh, so we're going to want to watch hepatic enzymes and see what our liver's doing. Peripheral edema, problems with blood pressure, weakness, leukopenia, neutropenia, and thrombocytopenia, anemias. Injection site reaction, again, they're pretty strong drugs, so we're going to watch where we're giving the injection at. Fatigue, insomnia, oral ulcerations are all things that we can see with these medications. So the first classification we're going to talk about is immunosuppressive agents, and just like it sounds, it suppresses the inflammatory process. And these medications are used to treat refractory rheumatoid arthritis. And if you see the word refractory, what you need to think about is that it is not responsive to normal treatment. So in this case, refractory rheumatoid arthritis, the patient who has refractory rheumatoid arthritis has tried other types of anti-inflammatory medications with no luck. If you have a patient with refractory hypoxia, that would be a patient who, even though you put on as much oxygen as you can on your patient, their oxygen levels will not come up. So refractory would mean normal treatment doesn't benefit the patient. So in this case, the refractory rheumatoid arthritis, the physician will try a little bit of a stronger medication. And these immunosuppressive drugs are typically used to suppress cancer growth. Methotrexate is immunosuppressive medication, prototype that you can know for this chapter. So normally used for cancer, but at a lower dose can be used to treat other conditions such as rheumatoid arthritis. Immunomodulators treat moderate to severe rheumatoid arthritis by disrupting the inflammatory process and delaying disease progression. Classifications include the interleukin-1 receptor antagonists and the tumor necrosis factor blockers. So if you see interleukin-1 or tumor necrosis factor, those play a role in causing inflammation. So if we have a receptor antagonist or a blocker, this should have blocker behind it, or tumor necrosis factor blocker, those are medications that are blocking those causes of inflammation within the body. Immunomodulators work by disrupting the inflammatory process, delaying disease progression, and neutralizing tumor necrosis factor. They're used for rheumatoid arthritis and some of those other types of autoimmune disorders that we can see in our patients. The prototype medication that you need to know for an immunomodulator would be infliximab. So if you have a patient who's going to be beginning infliximab, we'd want to get a baseline CBC and renal and liver function tests to see where their levels are at prior to starting the medication infliximab, and then we'd want to continuously monitor that while the patient is being treated. With infliximab, the patient can expect their pain to be reduced within 12 to 24 hours and inflammation to be reduced within 1 week. The patient will need to have a TB test prior to initiating the infliximab therapy, and if the patient shows any signs or symptoms at all of inflammation or infection rather, we'd want to stop the infliximab, discontinue the infliximab, and start antibiotic therapy. Again, infliximab is going to be turning down the patient's own immune system, putting them at increased risk for infection. We're going to want to monitor for blood dyscrasias, monitoring the CBC, and monitoring renal and liver function. When giving an infliximab infusion, we want to flush the IV tubing with normal saline before and after, and we want to deliver the medication through a filter. Each dose of infliximab will be administered over a minimum of 2 hours. And if the patient shows signs of an acute infusion reaction, such as chest pain, fever, chills, dyspnea, pruritus, urticaria, hypotension, or hypertension, we would want to discontinue that IV infusion. We want to monitor patients for up to 2 hours after the infusion for the acute infusion reaction. We will teach patients who are taking infliximab to avoid live vaccines while taking the medication. In terms of adverse reactions, again, we'll want to monitor for severe infections. It's something we're going to be concerned with: chest pains, problems with blood pressure, increased hepatic enzymes, anemia, neutropenia, pancytopenia, and also Stevens-Johnson syndrome. So watch for any sort of rash and make sure the patient would report any rash immediately. And finally, antimalarial drugs may be used to treat rheumatoid arthritis when other methods of treatments fail. The mechanism of action and how it works in treating rheumatoid arthritis is not quite clear. The effect may take 4 to 12 weeks to become apparent. And it is used again when all other methods of treatment fail.